Hello everyone, I'm Isha, and today I'd like to welcome all of you in CellTalk's webinar. Today we will have with us Dr. Divya Lakshmi Ramakrishna, who is going to present on the topic a molecularly integrated grade for meningioma. Dr. Divya has been a scientific content writer and team lead at Renix Life Sciences for 2 years. She has gained experience in operational, managerial, and administrative roles and scientific activities. She has explicit writing skills to present the articles in required formats such as blogs, white papers, disease summaries, descriptions, posters, etc., in various medical specialties within the focus on oncology. She is involved in enhancing the scientific research content collected from wide spectrum of literature to reach the target audience like patients, healthcare professionals. Currently, she is actively involved in the content creation of clinical gene maps project. Presently at Renix Life Sciences, she is managing multiple teams such as the content team, data acquisition, and health analytics, and successful in completing the deliverables from the teams through planning, task allocation, guidance, reviews, and approval. She is also experienced in proofreading, editing, and reviewing of the documents written by team members. Recently, she has played a major role in the initiation and execution of projects related to healthcare monitoring of senior citizens and rural healthcare programs. So, without any further delay, I'd like Divya to carry on it on.
Thank you, Isha, for this elaborate introduction. So, good evening, everybody. Today I'm presenting the article titled A Molecularly Integrated Grade for Meningioma. The author is Joseph Driver et al. And it is from the journal Neuro-Oncology, and the year of publication is 2021. So I'll just start with a brief introduction. As you all know that meningiomas are the most common primary intracranial tumors in adults. And the clinical care of meningiomas is mainly based on the WHO grading, which is further based on the histopathological features of the tumors. Whereas the hitch here is the behavior of this number of meningiomas does not conform to the assigned WHO grade because of various limitations. Hence, additional features are required which will have effect on the patient management as well as in analyzing the recurrence rate. Now, coming to the general background, the limitations of WHO grading system for the meningiomas is mainly because of the inter-observer variability in the histological assessment, the potential for the undersampling of the tumor type with known histological and molecular heterogeneity, and also the possibility that malignant potential is not uniformly reflected in the assessment of histological features. So molecular characterization here may present as an important factor to overcome these limitations of the WHO grading. So a grading system or a scheme which incorporates the mitotic index and multiple high-risk copy number alterations was proposed, which will help for the identification of patients at the risk for tumor recurrence. So this article is mainly based on the development of a molecular characterized integrated grade for the meningiomas. The various challenges here is again incomplete tumor sampling, inter-observer variability in the histological assessment, and ambiguity of the histological features, which are the challenges, and this may lead to the uncertainty of the patient management. That is why this aim of the study was to develop a molecularly integrated grading system for the meningiomas. Now, coming to the methodology, it was divided into the discovery cohort and the independent cohorts, and it consisted of totally 527 meningiomas, which were resected either by gross total resection or subtotal resection, and they were evaluated at the Brigham Women's Hospital. And the independent validation cohorts consisted of an addition of 172 patients with surgically resected meningiomas from the same hospital, and also a 55 patient from the University of Toronto were included in this study. The clinical annotation included the detailed clinical history, location of the tumor, the radiographic recurrence rate was assessed, along with the pre-operative and post-operative MRIs for assessment of gross total or subtotal resection. The follow-up MRIs were independently reviewed by 3 authors in order to evaluate the recurrence, and also the evaluation of the MRI images was done regarding the radiology reports and the clinical charts. Now, this discovery cohort, this is the schematic representation of the discovery cohort, as well as the number of cases which were included for the study. And later, following which the histopathological review was done, and the genomic characterization of also done for all the samples available. And this histopathological review was done by the neuropathologist, and the tumor grade was abstracted, which was based on the pathology reports, which was according to the same old WHO classification of the tumors. And also whole genome microarray analysis for the DNA copy number profiling was also done for about 527 tumors from the discovery cohort and 83 samples from the validation cohort. Also, the onco panels were done for 118 samples. Then a model design and validation of the samples were done, out of which 338 were the primary and previously untreated meningiomas with gross total resection from the discovery cohort were modeled for the recurrence rate. And then the covariates which define the WHO grading system, like the mitotic index, the presence of the atypical features, and also the brain invasion, they were investigated. And Cox-Lasso regularization, random survival, and the gradient boosting were the various regression analysis which were used. And this shared high-risk features were identified across the selection methods, and it was chosen for the model building to construct an integrated grade with best predictive performance for the tumor recurrence. Now, this integrated grade was further compared to the original WHO grade for predicting the tumor recurrence using the time-dependent receiver operator curves and time-dependent average precision curves and the Breeder curves. And also they were internally validated in the discovery cohort using the cross-validation techniques. And using all of the discovery cohort, which included tumors with varied treatment histories, the integrated grade was included along with the extent of resection, size of the tumor, the status of the tumor in the Cox proportional hazards model to generate a nomograms to assess the recurrence risk. And finally, a decision curve analysis was performed to evaluate the clinical utility of the nomogram. Now, coming to the results, the discovery cohort included 527 meningioma cases, and the different categories of the WHO grading, that is grade 1, 2, and 3, with 326 patients of WHO grade 1, 172 of grade 2, and 29 of grade 3 were included. And it was mostly 67% of female patients with a mean age of 57 years. And there were about 132 recurrences. These results were further categorized in 2 different categories based on the availability of the data of the results. Now, the first thing was the development of molecularly based integrated grade, which was the main objective of this study. Now, this integrated grade was devised, which accounts for the mitotic count, the focal hemizygous or homozygous loss of CDK and 2A, and also the loss of either the P or the Q arm of the various chromosomes or both the arms. And several high-risk chromosomes, which are 4, 6, 10, 18, and 19, They exhibited synchronous loss of short as well as the long arms when they were altered. And the mitotic count exhibited less variance, and all these features were assigned as 0.1 for the presence of any of the above chromosomal losses. And the CDKN2A loss also, and a mitotic count between 4 to 19, 1 point was assigned. Then 2 points were assigned for the mitotic count, which is greater than 20. And thus the tumors were divided into 3 integrated grades based on their point scores. That is integrated grade 1, 0 to 1 point. Grade 2 was 2 to 3 points, and grade 3 was higher than or equal to 4 points. So this pictorial representation shows the high-risk molecular alterations which were seen and which have been graded with the points. And the second part of the results was the association between the WHO grade and the integrated grade. For the 527 meningioma cases, 87% concordance was seen between WHO grade 1 and integrated grade 1, 31% between WHO grade 2 and integrated grade 2, and 72% with WHO grade 3 and integrated grade 3. Then the third part of the results was the correlation of the integrated grade and the clinical outcome. So the authors reported that in the subset of 338 primary non-irradiated meningiomas with gross total resection, the tumors demonstrated distinct progression-free survival by either the WHO grade or the integrated grading. Now, this integrated grade was compared to the WHO grading for predicting tumor recurrence using these 3 curves, that is the time-dependent receiver operator curves, the time-dependent average precision curves, and the breeder curves. Also, they found that the integrated grading scheme significantly improved the ability to predict the recurrence risk as compared to the WHO grade, and was evaluated by time-dependent ROC area under the curve and the breeder score. And the predictive capacity of the integrated grade compared to the WHO grade strengthened with the follow-up time as well. So in each of these cohorts, the study reported that the integrated grade was superior to WHO grade in predicting the recurrence. Also, the integrated grade was superior to WHO in assessing the overall survival on long-term follow-up. Coming to the discussion, an alternative to the WHO grading scheme for the meningiomas with the improved accuracy in predicting the tumor behavior was the main challenge which was faced here, and hence this molecular integrated grade was proposed. And the mitotic index, which is a proven reliable predictor of tumor behavior, and the various genomic markers significantly associated with recurrence have been previously observed in malignant melanomas, have been incorporated in this study. And this integrated grade is varied from the WHO grade in a substantial portion of 1/3 of the patient, and hence it may provide some clinical benefit also. As mentioned, the copy number alterations appear to occur early in the progression of the disease or the tumor and before the clinical detection. And this offers a predictive value over long-term follow-up as compared to the WHO grading. And also the copy number profiling is widely available in standard practice because of its demonstrated utility in the diagnosis of other tumors as well, and gliomas being a standard example. And also the accurate inference of broad chromosomal loss or gain from a number of genomic platforms is also available. And the binary readout of copy number alterations and the transparency offered by the point-based risk stratification system also enhances the ease of the interpretation. So an example of a genomically stable meningioma, that is an integrated grade 1, will have a best chance for long-term progression-free survival after complete excision. So given the high incidence of meningioma globally, this integrated grading framework will definitely have an influence on the care of thousands of meningioma patients worldwide. Whereas one concern for the integration of the genomic data into a grading scheme is the feasibility of its implementation in both the academic as well as the community settings. Now, the limitations of this particular study was the mutational coverage was incomplete, including those which were associated with prognosis. And there was a sparsity of certain WHO grade histological subtypes like the clear cell chondroid, rhabdoid, and the papillary type of meningiomas. A possibility is also that these subtypes may have other important genomic features driving aggressive tumor behavior, which is not captured by this integrated grading scheme. For example, SMARC1 mutations in clear cell meningiomas. Also, the methylation signatures, they were not available from the institutional cohort, limiting their comparison. Hence, to conclude, the authors concluded that the mitotic index and copy number profile can alone appraise the tumor behavior with satisfactory results and improve on the existing methods. Thus, the modular nature of the proposed risk stratified integrated grading scheme, it lends itself to a further refinement with incorporation of other additional access of genomic data. However, there is a need for assessment of large cohorts of meningiomas with rare mutations and of uncommon histological subtypes is necessary. The impact of this research is that the integrated grading can enhance the clinical care of meningioma patients. It has an immediate relevance to the improved management of meningioma patients, and it also can aid in the design of future prospective clinical trials. Thanks everybody for your patient hearing.
Thank you, Divya, for this very informative talk. Now I would move to the question box for the questions. So Nupur asks, does this study considers genomic mutations? Also, it appears it is focused on specific chromosomes. What happens for genetic alterations in other parts of chromosomes?
I mean, I didn't get your question, Isha. Can you please repeat it?
Sure. Does this study consider a genomic mutation? Also, it appears it is focused on specific chromosomes. What happens for genetic alterations in other parts of chromosomes?
Yeah, that is what is the one of the main limitations of the study, which they have mentioned that it does not completely cover all the chromosome. I mean the variations, and a very rarity of these mutations or the rarity of the chromosomal changes is not included as the in the grading of in this integrated grading system. That is one of the drawbacks or the limitations of the study.
Thanks, Divya. I hope that suffices your doubt, Nupur. There are no more questions in the box. Let's wait for a few minutes. Okay, so I don't see any question coming up. So before concluding today's session, I'd like to inform you about our next session, which is on the 7th of June 2023, to be presented by Bharti on the topic somatostate receptor theranostics for refractive meningiomas.